Atrioventricular nodal reentrant tachycardia. MD. DPERHC, AVNRT. The most common form of paroxysmal supraventricular tachycardia in adults, 60%. More common in women, 70%. Uncommon in children. Rate usually 130 to 250 bpm, 110 or more than 250. Atrioventricular nodal reentrant tachycardia, AVNRT. The concept of AVNRT as a mechanism of SVT was first proposed by Mainz in 1913. Nodal were the first to postulate that SVT could be due to longitudinal dissociation of the AVN2 pathways. These investigators postulated the presence of a dual AVN transmission system with a slowly conducting alpha pathway with a short ERP and a fast conducting beta pathway with a long ERP. AVNRT electrophysiological mechanism. AVNRT results from re-entry in the avenue node as a result of the presence of functional longitudinal dissociation within the avenue node. Slow pathway, alpha pathway. Slow conduction. Short refractory period. Fast pathway, beta pathway. Rapid conduction. Long refractory period, longitudinal dissociation within avenue node. Slow pathway. Fast pathway. Atrium. His bundle. AVNRT mechanism. Limb A. Limb B. Dual avenue nodal physiology. The hypothesis of functional longitudinal dissociation within avenue node was based on the presence of dual avenue nodal physiology in 50 to 90% of documented AVNRT patients and only in 5 to 10% of normal people. Occasional dissociation of this bundle and ventricular activation from the tachycardia. An initial impression that atrium could be dissociated from the tachycardia. Atrial participation. More recent studies suggest that fast and slow pathways represent conduction over different atrionodal connections. Different sites of atrial activation during retrograde atrial activation over slow and fast pathways. Resetting of tachycardia by late atrial extrastimuli delivered to posteroseptal right atrium or CSO. Selective elimination of fast or slow pathways by ablation in the atrium remote from compact AVN. Earliest site of retrograde activation. AVNRT. At least 4 distinct forms of AVNRT can be identified in a series of 499 patients. 1 slow, fast, comment type, 76%. 2 left variant slow, fast, 1%. 3 slow, 11%. 4 fast, slow, 12%. Typical AVNRT, 85 to 90%, atypical AVNRT, 10 to 15%. Fluoroscopic correlates. Fluoroscopic correlates. Koch's triangle. Approach. Approach. ACG manifestations of dual AVN conduction. Spontaneous abrupt prolongation of PR interval. SR with alternance of the PR interval. Simultaneous conduction along fast and slow pathway. Charles Fish, Jack 1997, 29. Adenosine can disclose dual avenue nodal pathway during SR. About 30% of patients has this morphology of QRS during tachycardia. Typical AVNRT. RP less than PR. R. P. Atypical AVNRT, Fast, slow. Tachycardia can cause syncope as a result of 1. Rapid ventricular rate, 2. Reduced CO, 3. Asystole when the tachycardia terminates as a result of tachycardia-induced suppression of sinus node automaticity. AVNRT mechanism. Possible circuits for AVNRT. Electrophysiological view of dual-avenue nodal physiology. Dual-avenue nodal physiology, AJUMP, is defined as atrial extrastimulus that causes an increase of at least 50 ms in A2-H2 interval for a 10 ms decrease in the atrial coupling interval, A1-A2. Manifestations of dual AVN pathways. 1. In increases of at least 50 ms in the I interval with 10 ms decrease in coupling interval of the APD. 2. Different PR interval or I interval during the sinus rhythm or at identical pace rate. 3. A sudden jump in the I interval during atrial pacing may be a manifestation of dual pathways. AJUMP. 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 Normal avenue nodal function curve. Discontinuous avenue nodal function curve. Some patients with AVNRT may not have discontinuous refractory curves, and some people who do not have AVNRT can exhibit discontinuous refractory curves. Retrograde jump. Retrograde jump. Multiple slow pathways have been demonstrable in the avenue nodal conduction curve in some patients with AVNRT. Multiple jumps. Multiple jumps. Multiple jumps. Multiple jumps. Avenue nodal echo beat. Avenue nodal echo beat. Avenue nodal echo beat. Induction of AVNRT. The VA interval during tachycardia is usually less than 50 ms measured at the HB, and less than 90 ms measured at HRA. Induction of AVNRT. Inducible by atrial extrastimuli or burst pacing at Winkie-Bach point in virtually all cases. Inducible by ventricular extrastimuli in 1/3. Pharmacological provocation by atropine, isoproterenol or propranolol may be necessary. If fast pathway conduction is suppressed, long Nodal cycle lengths or VA block, isoproterenol infusion may be useful. If ERP of fast pathway is very short, increasing the degree of sedation or infusion of beta blockers may be more helpful. Induction of AVNRT. Induction of AVNRT. Induction of AVNRT. Initiation of AVNRT by spontaneous pack. Initiation of AVNRT by spontaneous pack. AVNRT. AVNRT. Atypical AVNRT. AVNRT with LVBB pattern. AVNRT with LBBB pattern. AVNRT with RBBB pattern. AVNRT with RBBB pattern. AVNRT with 2-to-1 avenue block. AVNRT with 2-to-1 avenue block. AVNRT with 2-to-1 avenue block. PVC superimposed on is no advancement of A. PVC superimposed on is advancement of A and AVNRT. Spontaneous termination retrograde blocking slow pathway. Spontaneous termination retrograde block in fast pathway. Spontaneous termination of AVNRT with 2-to-1 avenue block. Termination with atrial extrastimulus. RA burst, entrainment and termination. RV burst, entrainment. RV burst, entrainment and termination. Amelioration of 2-to-1 avenue block by PVC. Treatment of the acute attack vagal maneuvers. Adenosine 6 to 12 mg for rapidly. Verapamil 5 to 10 mg for. Diltiazem 0.25 to 0.35 mg/kg for. Radiofrequency ablation indications. Patients with frequent arrhythmic episodes despite administration of drugs with a high safety profile, beta blockers, CA blockers, digoxin. Poor tolerance of drugs. Patients with pharmacologically controllable PSVT who prefer to avoid drug side effect. Management of patients with single or infrequent symptoms should be individualized. Radiofrequency ablation. Other indications. Empirical slow pathway ablation in patients with documented PSVT and dual avenue nodal physiology, but without inducible AVNRT. Identification of inducible AVNRT during the evaluation for ventricular tachycardia when the patient is a candidate for implantation of ICD. Radiofrequency ablation in children. RF ablation in the heart of young sheep is shown to result in serpiginous lesions that become larger as the heart grows. It appears prudent to avoid ablation when possible in young patients, especially if they are younger than 4 years of age. Radiofrequency ablation approaches. Fast pathway ablation, anterior approach. Slow pathway ablation, posterior approach. Radiofrequency ablation, slow pathway approach. Identification of target sites. Electrogram technique. Anatomical technique. Integrated approach. A prospective randomized trial comparing the two techniques found both to be equally efficacious. It is safe to cross over from one technique to the other as long as AVNRT persists. Slow pathway ablation electrogram approach. Fractionated atrial electrograms with AVNRT ratios of 0.1 to 0.5. Discrete slow pathway potentials, disputed. Multi-component atrial electrograms are sensitive but not specific marker for successful ablation. Successful signals. Successful signals. Successful signals. Slow pathway ablation anatomic approach. Slow pathway ablation. Slow pathway can be ablated along posteromedial TA close to CSO. Starting at the most posterior site, near CSO, and progressing to the more anterior locus, close to HV. Slow pathway ablation successful sites. Slow pathway ablation successful site. Slow pathway ablation successful site, RAW view. Slow pathway ablation successful site, LAW view. Slow pathway approach a marker for success. Accelerated junctional rhythm, a sensitive but not specific marker for success. An almost universal finding at effective target sites, 95%. Also at 65% of ineffective sites. A rapid junctional rhythm may be a harbinger of avenue block. Accelerated junctional rhythm. Accelerated junctional rhythm. Accelerated junctional rhythm. Slow pathway approach monitoring during ablation. Monitoring junctional ectopy for VA conduction and monitoring for prolongation of PR interval are important. Slowing of VA conduction during EJR may also be harbinger of avenue block. Avenue block occurs almost exclusively after burns associated with VA block during junctional ectopy. Positive predictive value of VA block during EJR for occurrence of avenue block is 20%. VA block during RFA. Slow pathway approach endpoints. Successful ablation is achieved when the tachycardia is no longer inducible in the baseline state or during infusion of isoproterenol. Up to 40% will have residual slow pathway function as evidenced by either odd jumps or single avenue nodal echo beats. Electrophysiological changes following slow pathway ablation. Prolongation of Wanke box cycle length. Prolongation of antegrade avenue nodal refractory period. No change in A interval. No change in retrograde conduction properties. Effective refractory period of fast pathway shortens. Electrotonic interaction. Avenue nodal conduction curve after slow pathway ablation. Slow pathway ablation recurrence rate. AVNRT occurs in 2 to 5% of patients. About 60% of recurrences are manifest within 3 months. In most studies, residual slow pathway function does not predict recurrences as long as no more than single echo beat can be evoked during isoproterenol infusion. Radiofrequency ablation fast pathway approach. Ablation catheter positioned slightly posterior and superior to his recording catheter. Avenue electrogram ratio of 2 to 1 or less with small his is optimal. Look for PR prolongation. VA block during junctional ectopy is expected. Fast pathway ablation site. Electrophysiological changes following fast pathway ablation. Prolongation of A interval, average 50%. Elimination or significant attenuation of retrograde fast pathway conduction. Elimination of dual avenue nodal physiology, in 85 to 100%. And significant changes in Wanke box cycle length and avenue nodal refractory period, fast versus slow pathway ablation. Slow pathway approach is preferred. Success rate higher, 99% versus 85%. Complete avenue block lower, less than 1% versus 10%. Fast pathway ablation may rarely be necessary when slow pathway ablation cannot be achieved. When assessment of successful slow pathway ablation is not possible because slow pathway conduction cannot be demonstrated reproducibly before ablation. Slow pathway ablation quality of life, QOL, and cost. Marked improvement in quality of life. The most cost-effective strategy in treatment of refractory cases. Quickly pays for itself in as little as 2 years. Booby and R.S., et al. Circulation 94 to 1585 to 91, 1996. Cowflesh, et al. Jack 19 to 1583 to 87, 1992.